We will go over the different diseases and illnesses found within the eyes and the ears. So refractive error, we'll start with problems of the eye. So refractive errors. So refraction is the bending of the light rays. So any problem with the eye length or refraction can lead to refraction errors. So myopia is nearsightedness. Hyperopia is farsightedness. Presbyopia is a loss of lens elasticity due to aging. It's less the eye is not able to focus for close-up work. And then astigmatism is when an image focuses at two different points on the retina. So these errors are diagnosed through a process called refraction. So the patient views an eye chart while different lenses are placed in front of the patient's eye. So non-surgical interventions include eyeglasses or contacts, and then a patient can have a surgical intervention known as LASIK to correct these. So legal blindness is when the best visual acuity with corrective lenses in the better eye is 2200 or less, and then the visual field is no greater than 20 degrees in its widest diameter. So those are the diagnostics for legal blindness. In a patient, as far as nursing interventions go, in a patient who is legally blind, it's very important to promote as much independence as possible. Examples include using a clock pattern for foods on the plate, providing remotes to them, using clocks that give the time orally or verbally. All of these things are going to promote independence. Cataracts. So cataracts is an opacity of the lens. It distorts the image projected onto the retina and can progress to blindness. So different causes of cataracts include aging. They can be hereditary. Trauma to the eye can cause cataracts. Long-term use of steroids or diabetes can lead to cataracts. Intervention is needed when the visual acuity has been reduced to a level that the patient finds unacceptable or when the symptoms begin to interfere with the patient's lifestyle. So assessment for cataracts. So early signs include blurred vision and decreased color perception. And then late signs of cataracts include diplopia or double vision, reduced visual acuity, absence of a red reflex, and the presence of a white pupil. Those are late signs. So the loss of vision is gradual with cataracts. Cataracts can be surgically removed. Post-op, you want to think about reducing the intraocular pressure. So you want to educate the patient on the importance of avoiding coughing, bending over, straining, or rubbing the eye. And then you want to keep the head of the bed elevated also to prevent increased intraocular pressure that would occur when lying the patient flat. So glaucoma. Glaucoma is an increase in intraocular pressure that results from inadequate drainage of aqueous humor. So glaucoma is a condition that damages the optic nerve and it can result in blindness if it goes untreated. There are two different types. You have primary open-angle glaucoma and then primary angle closure glaucoma. Primary open-angle glaucoma is your most common type. It's painless. The vision changes are slow. It eventually results in tunnel vision. This type of glaucoma, it's treated with miotic eye drops that constrict the pupils and thus decreases the production of aqueous humor, keeping that intraocular pressure within normal range. As opposed to primary angle closure glaucoma, which is a medical emergency. It causes sudden eye pain. This patient is going to have blurred vision, halos around the lights, and ocular erythema. In patients with glaucoma, it's very important to avoid any anticholinergic medications because those medications are going to increase the intraocular pressure. So for the NCLEX, certainly know the difference between primary open-angle glaucoma and primary angle closure glaucoma. Retinal detachment. So retinal detachment, it occurs when the layers of the retina separate because of an accumulation of fluid between the two layers, or when both retinal layers elevate away from the choroid as a result of a tumor. So when detachment becomes complete, blindness occurs. Assessment findings in a patient with retinal detachment. Definitely know these and be able to recognize these on the NCLEX. This patient is going to complain of flashes of light. They're going to complain of floaters, an increase in blurry vision. This one is key. They may have a sense of a curtain being drawn over the eye, and then they may have painless loss of central or peripheral vision. So the floaters or the black spots that they see are signs of bleeding. And then again, they're going to complain of the sense of a curtain being drawn down over the eye. So for this patient, you want to put them on bed rest. You're going to cover both eyes with patches to prevent further detachment and definitely prepare for surgery. Macular degeneration is a degeneration of the macula, the area of central vision. So you have atrophic or dry macular degeneration, and then you have exudative or wet. So dry is more common, but wet progresses faster. So atrophic or dry is just age-related macular degeneration. So it's caused by gradual blocking of the retinal capillaries, leading to the death of rod and cone receptors. Whereas exudative macular degeneration, or wet, is where fluid and blood collect under the macula, resulting in scar formation and visual distortion. So both are characterized by the presence of drusen, which is yellow deposits beneath the retina. The assessment findings for macular degeneration: this patient is going to have a decline in central vision. They're going to complain of blurred vision, distorted vision. Okay, ocular melanoma is the most common malignant eye tumor in adults. It's usually found in the uveal tract. It can be spread easily due to its extensive blood supply. This patient will complain of blurred vision. They're going to have an increased intraocular pressure. They may possibly have a change in their iris color as well. Patients with suspected ocular melanoma can undergo an ultrasound, which can determine the size and location of the tumor. Surgical intervention is going to be needed for removal. So enucleation is removal of the entire eyeball, whereas exenteration is removal of the eyeball and its surrounding tissues and bone. So a hyphema is the presence of blood in the anterior chamber. It usually occurs as a result of injury, but self-resolves on its own in 5 to 7 days. You want to be sure to keep this patient in a semifallow position, avoid any sudden eye movements, and you want to avoid excessive strain of the eye, so you want to limit any reading or television watching. Penetrating objects is obviously when an eye injury occurs after an object penetrates the eye. So if someone comes into the ER and they have an object that is penetrating the eye, you never remove the object because that object may be holding some ocular structures in place. The object needs to be removed by the physician. You want to cover the eye, usually with cup and tape it in place. You do not lie the patient flat or bend them over, as that's going to increase intraocular pressure. An MRI is contraindicated in this patient because you don't want, there's a potential for that object containing metal, and you don't want that metal to move during an MRI. Okay, chemical burn. So if you experience a chemical burn, it is very important you want to immediately flush the eye with water for at least 15 to 20 minutes at the scene of the injury, and then you're going to transport the patient to the ER. As the bedside nurse at the ER, you're of course going to assess their visual acuity. You're going to check the pH of the eye and then irrigate the eye continuously until that pH is at an acceptable level. If it's possible, it is ideal to obtain a sample of the chemical involved. That way it can be tested and the physicians can further know how to treat it. Okay, eye donation. So donor eyes are obtained from cadavers. So if a patient passes away on your unit and they are an eye donor, you want to raise the head of the bed to at least 30 degrees. You're going to instill antibiotic eye drops as prescribed. And then you're going to close the eyes and apply an ice pack on top of those closed eyes. After a patient has received and an eye donation. Signs of rejection of that donation include redness, swelling, decreased vision, pain. RSVP is a way to remember it: redness, swelling, vision, pain. And that will be treated with topical corticosteroids. Of course, in this patient post-op, you're going to want to keep the head of the bed elevated, and then you're going to do everything you can to reduce intraocular pressure. So for the NCLEX, it is very important to know the difference between conductive hearing loss and sensorineural hearing loss. So conductive hearing loss occurs when the sound waves are blocked to the middle and inner ear. So it can often be corrected and has little to no permanent hearing loss associated with it. So causes can be a physical obstruction, can be a tumor, or an inflammatory process. Treatment often includes hearing aids. So again, conductive hearing loss is caused by a physical obstruction that's interfering with the transmission of sound waves, as opposed to sensorineural hearing loss, which is often permanent, and it's caused by a pathological process of the inner ear. Causes include damage to the inner ear structures, damage to the 8th cranial nerve or the brain, prolonged exposure to loud noises. The treatment will be cochlear implants. Cochlear implants are like a small computer that helps to convert the sound waves into electrical impulses. It makes the sounds clearer versus hearing aids, which only makes the sounds louder. A patient can have mixed hearing loss, which is a combination of conductive and sensorineural hearing loss. It's a combination of both, but definitely know the differences for the NCLEX. Presbycusis is a sensorineural hearing loss associated with aging, so it's age-related hearing loss. So the hearing loss is going to be gradual and bilateral. The patient may report no problem with hearing, but they're not able to understand words that are being spoken, and the patient may think that the speaker is mumbling. Chronic otitis media. So anytime a patient presents with acute otitis media caused by a bacterial infection, it is very important to closely monitor that patient for improvement, because oftentimes, bacterial organisms may be resistant to certain antibiotics, and then this leads to chronic otitis media, which is just chronic infective, inflammatory, or can be an allergic response involving the structures of the middle ear. So it can also involve frequent removal of debris from the ear canal. Treatment may include a mastoidectomy. So mastoiditis can result from untreated chronic or acute otitis media. So it's whenever the patient will present with a lot of swelling behind the ear and pain with minimal head movement. They will have cellulitis of the skin of the mastoid process, a fever, and then a very red and dull, thick, immobile tympanic membrane from that prolonged otitis media. So this does require surgical removal of the infected material, which is called a radiomastectomy with a tympanoplasty, where the eardrum and the ossicles are reconstructed in an attempt to restore normal hearing. Complications of mastoiditis include damage to the abducens, the 6th cranial nerve, and the facial, the 7th cranial nerve. It can also lead to meningitis and vertigo as well. All right, otosclerosis. Otosclerosis is a genetic problem of the capsule of the middle ear. It results in bony overgrowth of the tissue surrounding the ossicles. So bilateral involvement is common, but hearing may be worse in one ear over the other. It can lead to both conductive and sensorineural hearing loss. So this patient is going to have slowly progressing conductive hearing loss. They may have a ringing or roaring, constant tinnitus in the ears. They will have very loud sounds when chewing, and they will present with what is known as a Schwartz sign, or pinkish discoloration of the tympanic membrane. Fenestration is removal of the stapes, the 3 inner ear bones. Complications include hearing loss, prolonged vertigo infection, or facial nerve damage. It just involves drilling a small hole into the foot plate, and then a prosthesis is used to connect the incus and the foot plate. Hearing, it's normal for the hearing to be initially worse after the procedure due to swelling, and there can be no noticeable improvement for up to 6 weeks. Okay, so inflammation of the labyrinth, if I'm pronouncing that correctly. So it occurs with complication of acute or chronic otitis media, just very similar to the mastoiditis, or it can be from a growth of a cholesteatoma. So this patient is going to complain of hearing loss, tinnitus, nystagmus, and vertigo. The most common complication is meningitis. So definitely in a patient with labyrinthinitis, you want to monitor for meningitis. So signs and symptoms of meningitis include a headache, stiff neck, lethargy, any mentation changes. Definitely be on the lookout. And then a cholesteatoma, it's an overgrowth of squamous cell tissue in the middle ear, in case that pops up anywhere. All right, Meniere's syndrome is dilation of the endolymphatic system caused by overproduction or decreased reabsorption of the endolymphatic fluid. Meniere's syndrome is characterized by tinnitus or ringing in the ears, unilateral sensorineural hearing loss, and vertigo. So symptoms can occur in attacks. They may last for several days. It's very important to institute safety measures for this patient due to the level of vertigo that they can suffer with. So again, this patient is going to have tinnitus, vertigo. They may have intense headaches, nystagmus, and feelings of fullness in the ear. Acoustic neuroma. So an acoustic neuroma is a benign tumor of the vestibular or acoustic nerve. Treatment is surgical removal of that tumor via a craniotomy. This may cause damage to hearing, facial movements, and sensations. Symptoms of an acoustic neuroma, they begin with tinnitus and progress to gradual hearing loss with time. Tympanic membrane perforations, Searman or Irax is the most common cause of impacted canals, which often leads to patients using Q-tips to try to disimpact them, which can lead to a perforation in the tympanic membrane. They usually heal on their own within 24 hours.